welcome everybody, both here in the room in London and also to our audience online to the Humanitarian Policy Group's World Humanitarian Day event for 2017, the impact of attacks against health workers. I'm Christina Bennett, I'm the head of HPG and your chair for today's event. Before we get started, could I ask all of you to turn your phones to silent, but please feel free to use them to tweet throughout the event. And the hashtag for today's event is #NotATarget, capital N, capital A, capital T. You should be able to find it. And I think we also have our handles on a slide that we'll be putting up later. So from armed conflicts to disasters to pandemics, many frontline workers operate in harsh environments, and I know this is not something that is new to any of you. It comes at a high cost to both their physical as well as their psychological well-being. And some have even made the ultimate sacrifice with their lives, as we saw in Syria last weekend, where 7 workers from the White Helmets Relief Group were killed. And as HPG traditionally does every World Humanitarian Day, and ahead of World Humanitarian Day this Saturday, we thought we would both celebrate the work of aid workers, because aid workers do incredible work at great personal and professional risk, but also reflect and commemorate on those who have risked their lives and their well-being in the service of humanitarian action. And today we'd like to focus on healthcare workers in particular, not only because of the large-scale, very violent attacks that we've seen increase over the past months and years against healthcare facilities and healthcare workers themselves, but also sort of the less visible side of what happens to healthcare workers as they're working day in and day out with communities in crises, and what that does to their psychology, to their emotional well-being, to their relationship with their families as they spend time in crisis-affected communities and then go home where the risk of attack and violence is still there. So according to the Safeguarding Healthcare Coalition's recent report, Impunity Must End, which one of our panelists will be speaking about in more detail in a few minutes, attacks on health workers, including threats, harassment, intimidation, and assaults, have occurred in 23 countries in 2016. According to the Aid in Danger report, in the first 6 months of 2017, we've had 62 attacks against health workers across 13 countries. So this is certainly a worrying trend that isn't going away. In addition to the risk of violence of health workers, they also risk infection, working in unstable environments, and also lacking basic infrastructure and supplies in the areas where they work. So they're not able to do the jobs they're meant to do. We saw this during the Ebola crisis, for example, where health workers were up to 32 times more likely to contract the disease than the general adult population. Similarly, in Syria, where health workers work in besieged conflict areas, they're compelled to set up kind of makeshift healthcare facilities in basements, in dilapidated buildings in order to provide the services they need to provide, and working in unsafe and unsanitary conditions. So as we pay tribute to humanitarian workers all over the world, and particularly to health workers, I'd like to welcome what we have as a distinguished panel, set of panelists for this discussion. I'm going to begin by introducing Len Rubenstein. Len is online from New York. He is the director of the Program in Human Rights, Health and Conflict at the Center for Human Rights and Public Health at the Johns Hopkins Bloomberg School of Public Health. Prior to joining Johns Hopkins in 2009, he was the Jennings Randolph Senior Fellow at the U.S. Institute for Peace, and before that, Executive Director and then President of Physicians for Human Rights, where he engaged in human rights investigations in conflicts throughout the world. He founded and now chairs the Safeguarding Health in Conflict Coalition, a group of humanitarian, human rights, and health organizations seeking to reduce attacks against health workers, patients, facilities, and transport. Next, we have Grace Carbo, who is coming to us from Sierra Leone. She's the operations director for World Vision in Sierra Leone, where she's worked there for 9 years. Grace played a pivotal role in the Ebola virus response when she led a safe and dignified burials team in the Bo region. Her team actually conducted over 36,000 burials of both Ebola and non-Ebola related deaths. Prior to working at World Vision, Grace was a lecturer and then later head of the Department for Development Studies at the Evangelical College of Theology in Sierra Leone. And I also want to call Grace out because she is now leading World Vision's response to the mudslides in and around Freetown, where 400 people have been killed and 600 people are still missing. And I want to extend a personal and particular thanks to Grace for taking herself away from this response, which we know is so important to be here on our panel today. And maybe she can give us some insights as to how that is going as well. Then we have Marwa Al-Junaid, who is the medical coordinator assistant for MSF Holland in Sana'a in Yemen, where she's been supporting the medical activities of MSF for the past 3 years. Prior to this, Marwa was an ER doctor at the Al Salam Primary Health Care Center, which is one of the MSF-supported hospitals in the southern part of the country. As part of Marwa's current job, she takes care of health staff. She collects data from projects, and she meets with other actors and coordinates with other INGOs to facilitate MSF's work. And finally, here in the room, we have Lee Daines, who is the Executive Director of Doctors of the World UK, part of the Médecins du Monde network, a position he's held since 2012. Previously, Lee was the Director of Advocacy Campaigns and Communication for Plan International and the Head of Corporate and External Affairs at the British Red Cross. Lee has worked extensively internationally from Afghanistan to Zimbabwe, at the headquarters of the ICRC in Geneva, and at the Red Cross's permanent mission to the UN in New York. So there we have our panelists, and I'm sure you'll all enjoy what they have to say. What I'm going to do now is sort of have a discussion among the panelists, ask them a bunch of questions, ask them to lend us their expertise and their insight. But I would ask all of you to hold your questions and your own thoughts until we turn to a Q&A, which I'll do in about an hour's time. After which we'll wrap things up, and there'll be coffee and tea outside for you to have and to have chats with your colleagues over. So unless there are any questions from anybody, I think we'll just get started. Yeah? Great. Len, maybe I'll first turn to you. According to the report, in the Impunity Must End report that was published by the Safeguarding Healthcare Coalition, attacks on health workers, health facilities, health transport, ambulances has occurred in 23 countries this past year. Can you talk us through that number and also what the types of attacks look like against health workers? This seems to me quite a worrying trend, and we're seeing already from this year's numbers that it's not something that's decreasing. Can you just tell us about that trend and if this is something that's ever going to go away?
Well, thank you, Christina, and thanks to ODI for hosting this. It's really a privilege to be part of this discussion. I wish I could be there in person. And it's also so appropriate to honor today all the health workers who are working in such difficult environments and putting their own lives at risk for others. The last question you asked was about the trends. I think we have to have a little context before I talk about 2016. It's only in the last few years that this issue has catapulted onto the international agenda. For years, the issue was just ignored, but we have to realize that back in the 1980s, health workers were being killed in El Salvador and Philippines. In the Bosnia War in the 1990s, more than 100 health workers were killed. In that same decade, in a 3-year period, more than 75 health workers were killed in Colombia. Before the Gaza war, 2 wars in recent wars, there were more than 100 Palestinian health workers killed. So this is not a new phenomenon. But I would like to share where we are. As you mentioned, there were 23 countries. I don't know if we have the map to show, but it doesn't really matter all that much. Countries are places where there are conflicts going on. There are very few conflicts in the world where health workers are not under attack. And one thing we have to understand, however, is when we ask whether it's getting better or worse, there's no good data. It's only this year that the World Health Organization is going to launch a project that is going to track attacks. There are very few data in places like South Sudan and many other African countries where there's war going on. Only in Syria has there been a concerted effort to collect good data on the numbers. And of course, the Syria numbers are completely stunning. We've never seen anything like the scale and intensity of attacks on healthcare in Syria. But just turning to our report, what we found is that in 10 different countries in the world, hospitals were shelled or bombed, and of course, health workers as well as patients were killed in those attacks. In 11 countries, health workers have been killed. In 20 countries, health workers have been kidnapped, subjected to various forms of violence and intimidation and kidnapping. In a number of countries, vaccinators have been killed. And just to give you a few numbers, I don't want to dwell on the numbers, but in Afghanistan, the UN reported 73 instances in 2016 of attacks on or intimidation of health workers. In Syria, Physicians for Human Rights reports 91 health workers killed in 2016. To report a slightly lower number of 74, but that just shows that the methodologies of tracking these attacks need to be further developed. People don't know, in the conflict in the occupied Palestinian territories, it's really a low-level conflict now. But in 2016, the Palestinian Red Crescent Society reported more than 150 of its emergency workers were injured. So why does this happen? That is the question everybody's asking, and there's not one simple answer. I think it's context-specific, but there are certain trends that we see. One is that armed groups and governments seek a strategic or military advantage. And a hospital is located at a strategic location, or it's where some armed groups have taken over, and instead of taking the necessary precautions to protect civilians in that hospital, as is required by international humanitarian law, the hospital is bombed. That's happened frequently in Iraq. Another trend that's extremely disturbing, and there are two sides of this, and very common, we see this all over the world. On the one hand, health workers are punished for providing health care to the enemy. Now, they're guaranteed, as we know, under international humanitarian law, the ability to provide care impartially. But in fact, they're punished. They're attacked, or in some cases, they're prosecuted as a crime of helping terrorists. The other side of that coin is that in many places, in Yemen, in Afghanistan, in many places, either state forces or armed groups demand priority for their own fighters. And they take over hospitals, demand that health workers give their troops, their cadres, priority. And if they don't, they either arrest or kill or injure those health workers. Those are very important trends. Another trend is utter indifference to the requirements of international law to take precautions against civilian objects and particular health facilities. And we see this in the Saudi coalition bombing in Yemen, where even though they have the coordinates of these hospitals, MSF and other groups share those with the Saudis, they're bombed anyway because they don't take the necessary precautions and bomb indiscriminately. Sometimes the attacks are just a matter of convenience or inconvenience, as the case may be. And we see this all the time at checkpoints and with ambulances, that they don't want to bother to check, as they have a right to do, an ambulance for weapons. And instead, they either shoot at the ambulance or intimidate the health workers. We see this endlessly in the Ukraine. We see this in the West Bank and Gaza. And so we have these various motives. And on top of that, we have armed groups who are attacking any group, regardless of its health work or any other form of humanitarian aid, because they are humanitarian workers, either because they see them as identified with the West, or they're part of a scorched earth military policy, as we see horrifically in South Sudan. So that's those are the overall trends we see, and it's extremely disturbing.
Thanks for that, Len. You know, it's interesting to hear you. I mean, I was struck in the report by the extent of the intimidation of healthcare workers, and thank you for explaining what the motivation behind some of that intimidation is. And the other thing that sort of shocked me about the report was what's happening on the other side. And the report is quite critical of the international community and the fact that it's pretty much turning a blind eye to some of these attacks, and member states in particular really justifying the fact that they can engage in these attacks, not doing very much about it at a multilateral level. Can you explain a little bit what this is about and what the solution might be?
Yes, thank you. As I mentioned a moment ago, there was indifference for many, many years to this problem. It wasn't on any screen, it wasn't reported, it wasn't investigated. The UN paid no attention, WHO paid no attention. But then about 5 years ago, in part for a lot of reasons we can discuss, it started getting attention. So we've gone from indifference to attention. And the next step was condemnation. We had resolutions from the General Assembly of the UN in 2014, and a major resolution in 2016 condemning these attacks and calling for actions to stop them and end the impunity. But now, since 2016, we've had paralysis, complete international paralysis. And that's a product of a lot of international political factors. Russia blocked any effort to have wonderful, detailed recommendations of the Secretary General to implement the 2016 resolution. So those recommendations have never been adopted. He called for a variety of actions by governments to prevent the attacks, reform their laws so health workers are not targeted, reform military practice, reform their investigation accountability procedures. That has completely stalled. They are not doing it, and there's not any accountability even for the steps to increase accountability. So there's paralysis there. There remains complete impunity. In part of our report, we looked at accountability, and we looked at 25 cases where there were efforts at accountability. In only 5 of the 25 was there even any kind of investigation or look at these incidents, and in none of them was the accountability adequate. So we're in a position where there is a road forward, but the paralysis and reluctance to take any steps, basically for political reasons, has stopped any action. We see another example of that in arms sales. We know, for example, in your country, in the UK, they're one of the major suppliers of weapons and munitions to Saudi Arabia, and those weapons are being used to bomb hospitals and other civilian objects in Syria, and that has stopped. The United States in the same position. The President of the United States wants to sell more arms to Saudi Arabia. So we have a problem that there has been rhetoric, there has been a call for action, there has become condemnation, but the action is utterly missing.
Thanks very much, Len, for the sobering assessment of what's happening even at the global level. I wanted to turn now to Marwa. Marwa, you are working on the front lines now in Yemen. And Len has just now painted a very bleak picture of what's happening to health services in crisis contexts. Can you maybe give us a little bit of a flavor as to what that looks like to you on the ground? How are health services, the types of health services that you are meant to be offering, how are they being affected by these attacks, by this intimidation? Is there anything that you can point to specifically as the impact of these trends on your work?
Health worker or on the health?
Sorry, Marwa, I don't know if you heard. On the services in particular, on the health services, what has been the impact of these attacks on health services?
Actually, from the beginning of the war, a lot of health facilities have been destroyed, and also the infrastructures, a lot of checkpoints, a lot of that's lead to this is lead to difficult. It's prevent, to the beneficiaries to get access to the health facilities, and also it's also difficult to the other actor and health actors to provide the medical assistance and medical and humanitarian assistance to those health facilities. So yeah.
Thank you. And you are living and breathing what the UN has called a catastrophic crisis, and you are subject to daily bouts of violence. What does it feel like to be somebody who has to focus on work every single day, day in and day out, knowing that outside of where you're working, there's chaos, and knowing that your friends and family are all involved in it as well?
Since the war began, we live and become a part of daily lifestyle. I go every day.
Marwa, could I ask you, we're having trouble hearing you. Could I ask you to turn off?
Any of us.
Marwa, could I ask you to pause for just a second? Can you maybe turn off your video so that we can hear your voice? And maybe that will work a bit better. Could you start again, because we missed the first part of your answer?
Okay.
Great, that seems clearer. Yeah, just turn yourself off. Yeah, go ahead.
So yes, actually, as live in such circumstance, it has been years since the fact that the stress and tension is become a part of the lifestyle. I go every day to work, and after that, any of us, either me, or my family, my friends, maybe get injured, and we may not survive. But it keeps me. I think. But what keeps me working under the circumstances, my desire to help my people, and try to relieve some of their pain and suffering by delivering medical services and humanitarian assistance to one who needs it, regardless of the political, sectarian, ethics, or political or religious differences.
Okay, thanks, Marwa. Is she still there?
Yeah.
Okay, great, Marwa. Maybe just a quick follow-up to that. What are some particular ways of coping that you have personally to be able to get through your day and to be able to work in a focused way and to be there to service your patients?
Yeah, as I mentioned before, I try just to focus on the work because it's. I used to live in such circumstances. So, seeing my people trying to relieve some of their pain and suffering, this is the motivation that's keep me. Doing my work, yeah.
Great, thank you, Marwa. And maybe now I'll turn to Grace. Grace, during the Ebola crisis, many of those who responded at the community level weren't really trained healthcare workers at all. And you yourself only had limited training when you began to lead those teams for safe burials. How did you feel as someone in that role who was leading, providing a frontline response for safe burials in such an acute and dire situation?
I was saying, for me and most of the burial team workers who were not trained health personnel, we were like moved to volunteer to do burials in order to save the nation, because people needed to volunteer to do the burials then. So being a frontline staff then was not about us, it was not about me, it was about saving lives. We were very clear. We knew that there's a possibility that we might not see the end of the fight against Ebola. We knew there's a possibility that some of us will not be there when it's over, but we needed to make this sacrifice in order to save the entire nation. So it was not about thinking about how am I going to make it. It's about let's do it, and let's do it. A few of us will go down, and forever, we will remember those heroes that went down in the fight to get us where we are today, to say Sierra Leone is Ebola-free. So yes, as a health worker, it was about saving the nation and about sacrificing. People needed to, and a few of us decided to do that. Though it was difficult that at the time we were rejected, we were not accepted, we were misunderstood, but yet we had to do that to save the nation. And that was why we were able to do the burials. Then, though we were not trained, just basic training, but yet that was a high-risk area, we were able to go out there and then do the safe and dignified burials in order to ensure that we are able to bring Ebola to an end in Sierra Leone.
Okay, thanks. You mentioned a rejection by the community as to the work that you were doing. Tell us a little bit about that rejection. I mean, what was the source of it? Was it because you were female? Was it because you were untrained? Was it the particular work you were doing? How did you cope with that rejection? And perhaps even a little bit of how you're carrying the effects of that into the current work that you're doing with the mudslides.
For many reasons, we were rejected. I will talk generally as burial team member, part of the burial team, and also as a lady being part of the burial team. Mostly people reacted that way initially out of fear. Mostly it was out of fear that, being part of the burial team is a high-risk area, and if you are in it and you come interacting with people, you are like danger. So the first thing to do, the first reaction was to reject. We don't want you guys, hey, stay off, keep off. And people were even asked to leave their homes. People lost their families because of that. And then also as a woman, in my country, death is mostly handled by men. It's kind of a taboo for women to be involved in burials. But because we needed to bring the dignified aspect to the burials, to ensure that women were buried in a dignified manner, women had to step forward and be part of this process. So yes, cultural reasons were also attached to this. Being a lady and then being involved in burials was like, it's a no. But then we had to do that. And talking about the effects of that, like psychologically and moving on, yes, there are a lot of effects around that, because then you have flashes in your mind when you look at those families crying, especially burying babies. For me was the most difficult part of it. Mostly under fives, it was very difficult. You have those flashes coming back. You see those faces. As you bury them, those families broken, torn apart. Yes, but then the strength that we had to continue to go on was that it was better to still sacrifice and continue this work and save more people than to pull out. So that was it. And with regards to the current disaster, the landslide, yes, we've been called upon again. The burial teams are conducting the burials for the victims of the mudslides, and we're working closely with the government and other partners to ensure that we are able to respond to this disaster.
Grace, are you experiencing the same type of rejection in your current work, or is this a very, very different type of situation because it's a different type of emergency?
It's a different type of situation now. Let me also hasten to add that, yes, now the burial teams, we cannot do an assessment around that, but I can say safely that they've been slowly accepted at this point, because people now realize the role that they played and how they sacrificed to save the nation. Though, from my personal perspective, they were not given the kind of attention that they should have received then, as a whole, internationally or wherever. But yes, they have been accepted that they played a key role. And currently, the government supported since then and is still supporting. The burial teams have been called upon to conduct these burials. And there is no resistance. People are willing to allow the burial teams. Some people are even identifying their loved ones, and they are saying, we'll allow the burial teams to bury. We are not taking them home. Some have the options to take them and bury them. So that's a great move to show that, yes, the work of the burial teams is being accepted now.
Great, thank you for that, Grace, and good to know that it's better than it was for you during the Ebola crisis. Maybe now just to come back here to London and to turn to Lee. Lee, you sort of represent the the international NGO, you're an executive director of a large organization. And I'm sure that you know that you have duty of care for all of your workers, whether they are health workers or otherwise, whether they're international or local or national. Tell us a little bit about what you consider to be good duty of care. What are some of your observations as to what that looks like on the ground? And how can it be improved? I mean, we've just heard from a couple of our panelists that they still very much are coping with lots of different psychological and physical effects. How can we improve their lives in the work that they're doing?
Sure. Hello, everyone. Perhaps first then to characterize what we see as threats to healthcare workers. And we see that in three ways. Firstly, as has been described very clearly, physical threats to healthcare workers. So, for example, last year in Syria, 6 medical units supported by my organisation, by Doctors of the World, were attacked. That resulted in the death of 15 healthcare workers and 53 patients. Secondly, we see threats to emotional well-being, to the psychological health of volunteers and staff on the front line. We ran an Ebola treatment centre in Sierra Leone. It was extraordinary to me to see really seasoned humanitarian doctors wrestling with the psychological effects of battling this invisible virus. And just to note that one of the most important contributions made to defeating Ebola in Sierra Leone was the work of Grace and her remarkable colleagues. So it's really humbling to be able to thank you in person today, Grace, for that really difficult work. But we also see threats to emotional well-being among the volunteers, both here in the UK and overseas, who are dealing with cases of extreme trauma and exploitation. For example, in our London clinics, where volunteer healthcare workers are meeting daily with trafficked pregnant women who have no access to healthcare, and their cases are extremely difficult to resolve. As something of a bridge, we just a few days ago published the story of a Syrian refugee. He's also a doctor, and he's now a volunteer in one of our London clinics. His name is Ahmed, and just briefly to say in his own words, "I'm a highly qualified medical doctor from Syria, but when I was about to complete my specialist training in oncology, I was arrested by government forces. I spent 6 months in jail where I was tortured, both mentally and physically. I was detained because I was saving lives." So of course we take duty of care extremely seriously. We have a raft of initiatives in place, not least the importance of pre-departure briefings, post-departure briefings, on-site support, access to appropriate counselling provision and services and so on, specialist training for those working with trafficked, exploited, vulnerable women and so on and so on. I think perhaps what's of more interest is what we as organisations should be doing better collaboratively. What could we be doing better together in a situation that Len described very elegantly as being one of paralysis, where the international community, amongst politicians where responsibility for these things often ultimately lies, there is no action, or the action that is taken is ineffectual. But briefly, just the third domain where we see threats to healthcare workers is threats to medical impartiality. So right now, if you are a patient in the UK and you go to see a doctor, which you have the right to presume is a confidential, private encounter, in fact, our Ministry of the Interior, the Home Office, is able to obtain your information from the National Health Service without your prior consent for immigration enforcement purposes. Similarly, our government is extending charging into the national health system. And this, for us, is not a question about eligibility. It's simply the position that healthcare workers are put in by virtue of government immigration policy. So it's a completely different context to Syria, but nonetheless, in our view, it is an as egregious threat to medical impartiality as instrumentalizing healthcare provision would be in a place like Syria. So these threats are really important to us. I manage and run an organisation, as you say. Actually, the reality is it's our volunteers and staff who bear the brunt of those realities day in, day out. And I'm sure you know that yesterday a very interesting report was launched as a contribution towards this debate by Humanitarian Outcomes, the Aid Worker Security Report. It's an annual report, and this year it focuses on the perspectives of perpetrators of violence against aid workers in general, and through first-person interviews with perpetrators of violence against aid workers, including healthcare workers. Those perpetrators are saying very clearly, we understand your rhetoric of impartiality, neutrality and independence, but actually what we really think is you're either a spy, or if you're not a spy, you're a profiteer. So I think moving forward there is something about understanding motivations, as Len touched on, in order to be able to enable us to move forward. So it's really well worth a read.
Great, thank you. But then on the specific question of duty of care, what do you see is your responsibility as MDM to your staff, and particularly as health workers, given the motivations, given the politicization that you just talked about, given the fact that although we say that the medical profession by nature is ethically impartial, and the humanitarian profession is principled and impartial, that we're not perceived as such. So how do you mitigate that? What's to be done?
Yes. So to begin at the begin, we have to make sure that we recruit, support and train appropriately skilled, qualified and experienced people, that we have the right people in the right place, that we offer the right types of ongoing training and support, including briefing and debriefing, that we have the appropriate reading of every security context, and those change and shift all the time, of course. And part of that requires us to be good partners of others, collaboratively in those situations, to make sure we understand the context and how to adapt and react. Ultimately, and there are always things we can learn, and there are always things that we could do differently and better. And so feedback is important, and we ask our patients for that feedback. Ultimately, of course, we do find ourselves in a situation in relation to acceptance and politicization, as you're touching on, Christina, of some of those states party to the Geneva Conventions who themselves are committing egregious violations of international humanitarian law, which quite legitimately begs the question, well, is any of it valid anymore? How will we ever implement effective protection for healthcare workers? And how will we ever enable them to have access to populations in need when states who are party to those conventions disregard them, flout them, and seemingly there's no impunity or accountability? I think that's something about, of course, intergovernmental political processes. There are organizations mandated to lead us on our behalf to try and tackle those difficult questions. But actually, where is the uprising of healthcare workers? We're making a really limited, modest contribution in the UK to mobilising health workers to stand up against compromises to medical impartiality wherever those threats occur. Some organisations are pursuing some really helpful, interesting awareness-raising campaigns like Healthcare in Danger. It's a really important contribution. My organisation has a campaign called Targets of the World. We don't want to be targets, we're not targets, we're doctors of the world. And so on. But these are only small, modest contributions to what could and perhaps should be a much wider uprising of healthcare workers saying, enough is enough, we are not a target.
But then what does that do? What does the politicization do to the morale of trained doctors who have taken the Hippocratic Oath, who have accepted their role as being an impartial one? Is the lack of activism due to a loss of morale when you've got a trained medical doctor having to face these horrible situations?
No, I mean, I think if you're an NHS doctor in the UK day in, day out, dealing with the system that you work in, no one would question your commitment. And I think this creeping, insidious undermining and chipping away of medical impartiality here because of government immigration policy is something which is taking people by surprise. I think there are probably many healthcare practitioners in this country who have no idea that going to see a doctor is no longer private or confidential, potentially. I think it's one responsibility that we bear as organisations is helping people make those links, bridging those gaps, trying to describe the human impact of what compromises to medical impartiality, threats to healthcare workers means in reality, in practice. One specific challenge from a UK perspective, I think, is that the whole access to equitable, accessible healthcare is so wrapped up inside politicised rhetoric about managing and controlling migration, stopping people getting in boats, that it's really hard in practice to keep a clear focus on the right to health.
Okay, great, thank you. We've talked a lot about the challenges, the problems, some of the, some positive trends, some very worrying trends. I want to maybe move to a quick round of discussion with everybody about what do we do about all of this? And maybe starting with Marwa and with Grace, as people who are on the front lines of humanitarian action in these situations, what would be the one thing that you would like to see happen within your organization or globally to make you feel more safe and secure as frontline health workers and able to do your jobs better? Maybe we'll start with Grace.
Thank you very much. One thing I would like to see happen is to be in a place where you are able to sacrifice and you will feel safe doing that. And that is to say, we are able to work with our community people. I'm talking from the background from where I'm coming from. Our community people, citizens, and let them understand the role of health workers, and even those of us who are not health workers, but are willing to be out there to save everyone. Even in the process of us not being safe, we are willing to do that. We want to see an environment where we feel safe, where we are not attacked, where we are not called names, where we are not spoken to in a demeaning manner, so to say. So I will recommend that we continue to work, government as well as non-governmental organizations. We continue to work because we're doing it with citizens to ensure they are able to understand. Because when people have knowledge about something, it will influence their attitude and their behavioral patterns. So it's key for us to work on that. But also I'd like to bring something in quickly around the burial teams. Now as a nation, we have a database of burial team members across the country who could take up burials any day, any time if we have disasters or anything happening that is bad, that we need the burial teams. But there is need also to focus on them. Most of my colleagues are not well educated. Some of them dropped out of school. Some of them need some training. So maybe a package can be put aside also to support these teams, to get them back into the communities and being able to get a form of livelihood, but still remain as standby workers that can be called upon to always come and support where there is need. So for me, that's what I would like to recommend those two. We continue to work with communities to ensure we have a safe environment for health workers and those who are willing to sacrifice. And we concentrate also on those who have sacrificed, the burial team members, to ensure that we build their capacity to be able to be ready to support and come back and just sacrifice as and when need be.
Great, thank you, Grace. Very clear recommendations there. Well, why don't we move on to Lee and Len, and then maybe we can get Marwa back for a final comment on that. Maybe starting with Lee. I mean, you talked a little bit about the various degrees or the various levels of challenges that you face as an international NGO in this environment of politicized healthcare and health services. At a global level then, like thinking very big picture now, and thinking in the realm of the international community, in the multilateral, with the multilateral community, what can be done to make sure that the motivations to minimize these politicized motivations against health workers, and to minimize the resulting violence against them, so that your organization is able to do the good work it's meant to be doing?
Okay, so it's something about the apparently particularly low ebb that the way in which wars are fought now has reached, and ending the apparent normalization of violence against healthcare workers in a context where there appears to be very little accountability and no impunity. Secondly, also I think it's, we have legitimacy as organizations because we have access to people in need, but effectively often our access is blocked. So in addition to challenging and seeking to end this apparent culture where violence against healthcare workers has been normalized, partly by the activities of some states directly and others, we also have to keep up momentum to get access to those people that need us. How that's done, well, it isn't working right now, some would say. And I do think it is about organizations coming together, forsaking their brand names, identities and mandates perhaps, to light a fire, to spark an uprising, including amongst healthcare workers. If we can't stand up for one another, how will we ever move forward? I think there will always be a place for good data, making the case through evidence. But I think it is also now about understanding the interests and the incentives that those who perpetrate violence have, because they continue to commit those atrocities, and to particularly understand the burden that therefore falls on national staff and volunteers, who in reality often are the ones who deal with this. I invariably don't. But I think it is something about lighting fires in a good way.
Okay, no, good. Positive response to that question. Marla, I think you're back. I wanted to be able to put this question to you again because I think it's really important to hear from you on this. Can you maybe come back to my question about the one thing that you would do or you would ask from your organization in order for you as a frontline health worker to feel more physically safe, psychologically safe, and more able to do the work that you're meant to be doing?
Yeah. So I think that we can. Hello. Yeah. So I think that we can communicate more with the community, and also coordination with the other authorities and with the authorities that we that present in the ground that we are working. It would be better. It will protect us more and will feel more safe. So, no?
Yep, we can hear you.
Yeah. So I can share personal experience, and so I can share the personal experience and how we incident because of the commission with the authorities in was in a morning shift in the emergency room in one of the hospitals supported by MSF in the south, which is 10 minutes from the Frontline. And I remember that we soon. I still remember that on that day we received more than 30 wounded. We usually receive the wounded from one side in this health center, but on that day we were receiving wounded from both sides. We were overwhelmed, and we had to put the wounded on the ground in the corridor and even in the area because we did not have enough beds in ER. They was ever jumping between patients trying to help them, and me and my colleagues. suddenly people came in and pointed their guns on our faces and asked us to stop helping their wounded kids and to leave the hospital. I still remember that day, so how we felt and how frightening that situation was. People and wounded screaming from pain and fear. And that day ended when our program coordinator contacted with the community leaders, with one of the community leaders, who took the gunmen out of the health center. So better communication and coordination between us and the community and the parties will make us feel more safer in the hospitals that we are working in.
Okay, thanks, Marwa, for that anecdote. It's really interesting that the three of you actually have talked a little bit about how to positively affect this dynamic through more community acceptance, through more livelihood support, through more coordination and collaboration on the international stage toward confronting this problem. But Len, just maybe coming to you for a final set of comments. A lot of what you said in the report, or a lot of what your group said in the report, was about a lack of accountability and a lack of sticks, if you will, to be able to push states to be accountable for what they're doing and for also the commitments that they've signed up to, both in terms of international law, but also Security Council resolutions. In your mind, at a global level, what can be done to improve that accountability, both within the Security Council or otherwise?
Well, first, I think my colleagues' comments are really important about how you support health workers on the ground. And I would add to what they say, this is to donors as well as organizations, that there's just such a dearth of psychosocial support for health workers working in these fraud environments. I've talked to dozens of health workers in Syria, and they get salary support, they get supplies, they get a lot of physical or material support, but they don't get psychosocial support, and they're suffering enormously from this. And that is deserved, it's warranted, and it's also critical. So we need to do that. But to get back to your question, I think we need to find concrete ways to put pressure on the international community to live up to its own commitments. And some of those steps are really quite simple. I mentioned all the commitments that the international community states made, taking specific actions. We don't have any evidence that actions are taken. And the only way to get them to do it is to shame them. And in order to do that, and they're not voluntarily reporting what they're doing, as the Secretary General asked them to do. Are they changing their laws, stopping criminal prosecutions of health workers for impartial behavior, accountability, investigations? They're not doing that. So we need an external entity to do that. And I think what needs to happen is the Human Rights Council needs to have a resolution that the High Commissioner of Human Rights will issue regular reports. What are states doing? And of course, it will also show what states are not doing. And it's not the most powerful mechanism we have, but it's the only one we really got at the moment. And I think that would go a long way to forcing states to take the actions that they have committed to do. These reports should come out annually. Who is doing what? It could also be useful as a model for good practices. That once a government has changed its laws, a government has changed its military doctrines and training, that is a very concrete step, and it's not going to happen through the Security Council. So we have to find other mechanisms, and that's why I think this would move the ball. It's not going to solve the problem, but it could move the ball.
Okay. Great, thank you. I really enjoyed actually reading the Impunity Must Stop report because it has very specific recommendations in that regard, which I think are very well taken. So I encourage everybody to if you're interested in this topic, to take a look at that report because it does have some very specific asks of the international community as to what can be done.
It's on the web. Here it is.
Great, thanks, Len. Listen, so thanks so much to all 4 of our panelists for engaging in this discussion with me and indulging me in my questions.